Welcome to ANZIC's Meet the Expert podcast series, that is Intensive Talk. In this podcast series, we meet with experts around the globe to discuss various challenges that we are facing as a community and understand how experts look at this problem. Hi, my name is Swapnil. I work as intensive care specialist in Sydney, and today it's my honor and privilege to welcome Professor John Marinin from Minnesota. This name doesn't need any introduction. He's a well-known expert in mechanical ventilation in ARDS. He has published extensively on the concepts of ventilator-induced lung injury and ventilator power and energy. So first of all, welcome, Prof.
Thank you, Swapnil.
So, Prof, you have published extensively in the field of ventilator-induced lung injury. So what's your perspective on lung injury in COVID-19?
Well, Swapnil, everyone is trying to put all the pieces together, but here more than ever, it's important to have a perspective that it's multifactorial and that this particular variant of the broad category we call ARDS is different. Why is it different? It's different because it attacks the endothelium of the blood vessels throughout the body, but because the body has a blood flow that pours extensively through the lung, in fact, the entire cardiac output goes through the lung, vulnerable pieces of the lung begin to injure maybe earlier than any other organ. In so doing, it initiates a type of ARDS in which considerations of what's happening on the vascular side of the alveolar capillary membrane is incredibly important. And here, at least in the early phase, there is a departure from what we expect to occur and what actually occurs. The other interesting thing about this disease is that it affects all organs in the system, in the body, particularly those that receive high vascular flows. It attacks people who have pre-existing vascular injuries or predispositions to vascular injury, namely diabetes, hypertension, advanced age. The fact that the compliance of the lung unexpectedly is very good. When the patient is first intubated and you can measure the compliance of the lung appears to be quite flexible, and therefore the techniques that we use to open the lung are really not necessary and actually divert blood flow to the wrong areas.
Thanks, Prof. And I think that's a nice segue into the next question. And you mentioned about the VILI vortex. A lot of the listeners might not be familiar with this concept of VILI vortex. And do you think that VILI vortex or this concept of ventilator-induced lung injury is the reason for high mortality in COVID-19, especially in that early phase when we are applying the ARDS mechanical ventilation strategies?
So the short answer to your question is yes, it contributes. No, it isn't the entire explanation, but it may set in motion.
So what's your thoughts on ventilation strategy in the early phase, and what's your recommendations to avoid this VILI vortex?
What's important is the power that is concentrated on a lung that becomes progressively smaller and more vulnerable to the concentration of power needed to keep the ventilation and oxygenation where they should be. I think one principle is don't let the patient struggle. Don't let them struggle to breathe. Don't let them have a high minute ventilation demand. Don't make them have a high oxygenation demand. And that means keep them calm, keep them comfortable, try to reduce high fever.
Can you please expand a bit more on the concept of ventilator power and what are the implications of those concepts in COVID-19?
No, all of those things are pieces of a puzzle. And the intersection of stress and strain is the energy that is imparted to the parenchyma of the lung, which varies from place to place in the lung. So you may have some sections that are quite vulnerable to injury because of excessive strains and energy that is required to produce the excessive strain. Well, it's the flow resistive plus the driving pressure plus the PEEP, actually multiplying by volume first to get the energy per cycle, and then by the ventilator frequency gives you the power that the ventilator and the patient, if you're measuring transpulmonary pressure, are putting onto the lung.
Thanks, Prof. So I just noticed that you use the terminology called as CARDS, and I imply that COVID-induced ARDS or ARDS in COVID. And I noticed a few hours ago, you just published a paper in JAMA Insight highlighting the managing the respiratory distress in COVID-19. So can you talk us more about what is in the paper and what is this CARDS concept is?
I called it CARDS simply because it's easy to remember. It distinguishes from ARDS in general. It's a specific form of ARDS. And it actually implies a little bit the cardiovascular side. It's COVID-19 ARDS, but if you want to interpret the C as cardiovascular, particularly vascular, that's a mnemonic too. It's to make people understand that this may require either the type H approach or the type L approach, which are two polar extremes of.
Absolutely. And I think as we move forward in this pandemic, we will understand better about the disease process. And it's kind of a reminder that even the ARDS terminology was coined back in 1967. It took probably 50, 60 years for us to understand ARDS concept, and probably we're still learning about this concept. And I guess COVID-19 is just a few months old now. So obviously it will take probably longer than a year or so to understand the whole disease process completely and kind of come up with some valuable interventions.
What we call ARDS is often not what Tom Petty and Ashbaugh presented in 1967. They talked about a stiff lung, low compliance. They visualized it as diffuse lung injury. We have made it almost disappear from our understanding of the stiffness part of it, the low compliance part of it. And therefore, these people with COVID who have actually good compliance, decent compliance, don't really fit what was imagined as ARDS all that time ago. And I have been concerned about these definitions that are used in trials because the trials are wonderful pieces of information. They give us lots of insights and so on. But unfortunately, it's such a broad definition, and it's an oxygenation-based definition. Really, when you think about it, it's a deterioration and a refractory oxygen exchange that's of relatively acute onset. They're talking about 7 days. Okay, maybe 7 days. But that's not what Tom Petty was thinking about. And so CARDS is a subdivision of ARDS, and whether it fits perfectly with Tom's conception of ARDS early on, I would say it does not, because the lungs are flexible. Later on, after the virus and the doctor do their dirty work, it becomes a quote stiff lung, actually a baby lung, vulnerable to the VILI vortex.
Yeah, I think that's very important distinction. I think sometimes we become too rigid with the timelines or too rigid with the numbers. And I clearly applying the numbers to a syndrome, which includes the different manifestations or different disease processes, might not be the right fit. Now, as you mentioned about trials and publications, and I know you are a reviewer for reputed journals, and you must have seen and reviewed a lot of recent literature on mechanical ventilation in COVID-19. What is your thoughts when you read this literature, and what's the kind of key messages embedded in this literature?
My thoughts are that the literature is very diverse right now. It's impulsive. There's a high premium on rapid publication. The quality is variable. Some of the information is incredibly useful and important. The stuff that I really pay attention to is the autopsy stuff. That is unusual. Secondly, we don't know enough right now to collect information fast enough to get valid information extracted.
Thanks for voicing those genuine concerns, because when I read the literature, it almost concerns me, because some of the clinicians who don't have time and who are flooded with this number of patients might not have time to interpret the literature in depth as we normally do and go through the vigorous process of peer review. And sometimes you are very tempted to adopt any treatment that is floated in that literature, to adopt very quickly and then experiment in your patients, and that might actually cause more harm. And I think clearly it has exposed the intensive care research community to some extent that we were not prepared to deal with these challenges of research in this pandemic context. And hopefully in the future we will be a bit more prepared in order to how to collect the information and how to publish it kind of in a rapid manner, but without causing any more harm. And it almost seems like we are going back to 60s and 70s, where there was not much information about those particular disease processes. So we are in a phase of observation, collecting information, discussing with different researchers, and coming with some sort of meaningful concept. And I think we have to kind of do that again, because it's a completely a new disease process.
Well said, Swapnil. And, you know, as someone who's invested their lives in clinical physiology and research, because I think it's the root of the skill set that critical care physicians need when you have a changeable problem.
Yeah, no, very well said, Prof. COVID-19 in a way forced us to reflect moving forward, that how we will change our practices in intensive care, and what are the kind of skill set we need to adapt to this rapidly changing environment of the disease processes. And it has clearly forced us now to kind of take a step back, pause, and then reflect. And I think hopefully we as the intensive care community will do that once this whole pandemic is over. Thanks, Prof. It was a pleasure talking to you, and thanks for spending a valuable time with all of us.
Thank you, Swap.